Okay, excellent. Good morning, everyone. Welcome to PHLP's Medicare 2024 webinar. Thanks for joining us today. My name's Erin Gay. Katie McKee and I will be doing the training today. So I am a white woman with short brown curly hair, wearing glasses and a purplish bluish sweater today. Everyone should have received the PowerPoint this morning around 9 o'clock. After the training, we'll send out a link to the recording and I'll resend the PowerPoint with that information. I'll also put the PowerPoint in the chat today, just in case you didn't get it via email. We'll have a survey at the end of the training today and in the follow-up materials, and we'd appreciate everyone taking 1 to 2 minutes to complete that survey to help us improve this training for next year and help us improve other trainings that we do throughout the year. If you have questions during the training, which we encourage, please put them in the chat, put them in the Q&A box. We'll stop periodically throughout the presentation to address questions, and we'll do our best to get to as many questions as we can and respect the noon end time. We always have a lot of information to cover, and this year is no different. If anyone experiences any technical difficulties during the webinar, please try logging off and logging back in. And then if you still need help, please email me at eguay@phlp.org. I'll put that in the chat as well. Closed captioning is available for today's session. So to see the closed captions, you must click the 3 dots on your webinar control panel and then click show subtitles. If you're seeing subtitles and don't want to see them, then click the 3 dots and click hide subtitles. So with that, I will turn things over to Katie to get started.
All right, thank you, Erin. Welcome and thank you for being with us today. My name is Katie McKee. I use she, her pronouns. I am a white woman in my 40s with short blonde hair, wearing an orange sweater. Erin and I work out of the Health Law Project's Pittsburgh office, and we are both pleased to be with you today to talk about Medicare in 2024. All right, so I'm gonna share my screen so we can jump into the PowerPoint. All right. So let's get started. Just a little bit about the Health Law Project for any folks who aren't familiar with our office. Oh yes, and I forgot, let's launch a poll to start with, just to get what everyone's Medicare knowledge is. Thanks everyone for answering that poll. We always we're going to be going over some basics, we'll be going over some more intermediate stuff. So I know some of this will be review for a lot of you, but it's nice for us to just have a sense of who's here and what kind of Medicare knowledge you're coming in with.
Great. We have a nice mix of people in terms of their knowledge of Medicare today. So thanks for answering. Okay. I won't launch any more polls, Katie. I'll be the only one right now.
For now, yeah, we want to keep you folks on your toes. We know this is an exciting topic. So just briefly to get us started, the Pennsylvania Health Law Project is a free legal services program. We help people statewide with Medicaid issues, people who are having trouble accessing Medicaid health insurance or who are having trouble accessing Medicaid covered services. Our primary focus really is working with people with Medicaid, but we help a lot of folks who are lower income or lower asset Medicare beneficiaries as well. And so you'll see as we go through the presentation, that's really the focus for us as we're talking about what's changing with Medicare in 2024. If you don't get our newsletter now, you can sign up on our website to join our newsletter. We have a helpline that's open currently on Mondays and Wednesdays starting at 8 o'clock. You can reach our helpline either by phone or by email, and we have really a wealth of consumer and advocate education materials on our website. So we encourage folks to check out our website, sign up for our newsletter, and reach out to us if we can be of help. All right, so we're going to start today by going over just a review of Medicare basics to make sure we're all on the same page. We're going to go over the Medicare updates for 2024, including coverage options and costs for 2024. We're going to talk about programs that help with Medicare costs, a little bit about dual eligibility for folks who are eligible for both Medicare and Medicaid. And then, because we can't help it, we're going to talk a little bit about the COVID public health emergency unwinding, because we are working with a lot of older adults who have Medicare and Medicaid who may be impacted by that unwinding. And we figure many of you are also working with that same population. So Medicare is a huge program. Medicare is a federal health insurance program. Currently, there are 66.2 million people covered by Medicare. Just to give you a sense of the scope of the program, that's 19% of the US population. So tons of people in the United States are covered by Medicare. In Pennsylvania, 2.8 million people are covered by Medicare. And we know many of these folks are dual eligible for both Medicare and Medicaid. So Social Security handles the eligibility end for Medicare and handles enrollment in Medicare Parts A and B, and is also the agency through which people can apply for the extra help program that we're going to talk about later in the presentation. The Centers for Medicare and Medicaid Services, or CMS, oversees and administers the Medicare program and handles enrollment in Medicare Advantage plans and Part D prescription drug plans, and also oversees the administration of the Extra Help with Prescription Drugs program. Medicare coverage is broken down into a few parts. So when someone goes on to Medicare, they get a red, white, and blue Medicare card. That red, white, and blue Medicare card provides someone's Medicare Part A and B coverage. So Medicare Part A is also called hospital insurance. This generally covers the care people get when they're inpatient or in a facility, or the care that people need following inpatient care. So if somebody has a hospital stay, Medicare Part A covers short-term care in a skilled nursing facility or rehab facility, and then some home health services after a qualifying hospital stay, and also hospice. Medicare Part B is Medicare's outpatient coverage, and so this is the part of Medicare that covers most of the care that people get on a regular basis. Medicare Part C is also known as Medicare Advantage or Medicare Managed Care. This is not a separate benefit, it's just a different delivery system. So people can choose to receive their Medicare Part A and B just through the original Medicare program using their red, white, and blue Medicare card, or they can choose to enroll in a private Medicare Advantage plan that's managed by a private health insurance company. Some people are more comfortable with that because they're used to having health insurance through a managed care company. Medicare Advantage plans must cover all Part A and B services. Anything that Medicare covers, Medicare Advantage plans have to cover. And Medicare Advantage plans can also offer some extra benefits, which is why they're often enticing to people. If you're enrolled in a Medicare Advantage plan, you have to follow the plan rules, meaning you're limited to the Medicare Advantage plans network. You need to see doctors in the network. There may be prior authorization requirements, other rules and requirements to receive care. And then Medicare Part D is Medicare's prescription drug benefit. So people who have original Medicare, they use their red, white, and blue Medicare card to get their hospital or outpatient care, need to enroll in a separate Part D prescription drug plan for their prescription drug coverage. If someone chooses to enroll in a Medicare Advantage plan instead, most Medicare Advantage plans include this Part D prescription drug coverage. There's lots of different plans available. Erin is going to talk a little bit about the number of plans available in Pennsylvania in 2024. Each plan is going to have its own formulary, and different rules and pricing structure depending on the plan. All right, so who qualifies for Medicare? People who are age 65 or older or have been receiving Social Security disability benefits for 2 years, or folks who have end-stage renal disease and are receiving dialysis or have had a kidney transplant. Those are the folks who are eligible for Medicare. If you're known to Social Security when you turn 65, you'll receive a Welcome to Medicare packet and a Medicare card. If you're not getting Social Security benefits when you turn 65, which is more and more common, people do need to take action and contact Social Security to enroll in Medicare when they turn 65. ESRD Medicare is not something that we work with a lot at the Health Law Project. It's primarily dialysis clinic social workers or transplant social workers help folks who are in that situation complete and submit forms to Social Security to enroll them in Medicare. So there are enrollment periods that apply to Medicare, and we're going to talk about that a little more. Medicare is different than Medicaid in that you have to enroll during specific enrollment periods, and if you don't enroll when you're first eligible, you may have a gap in coverage or have late enrollment penalties. So we're going to talk a little bit more about those enrollment periods. So people can enroll in Medicare Part A and B when they are first eligible. When folks are first eligible, they have a 7-month initial enrollment period. That starts 3 months before you turn 65, the month that you turn 65, and then the 3 months after you turn 65. That's your initial enrollment period. Generally, it's a good idea to enroll in Medicare when you're first eligible, unless you're still working and have employer covered health insurance. And even then, you may still want to enroll in Medicare. So there's a lot of considerations. For the most part, when we talk to folks, we recommend if you're becoming Medicare eligible, you should enroll. For folks who don't enroll during their initial enrollment period, there is a general enrollment period every year from January through March. Coverage starts the first of the month after you enroll. If you use the general enrollment period to sign up for Medicare Part B, you also now get a special enrollment period to enroll in Medicare Part D. So if you miss signing up for the various parts of Medicare when you were first eligible, the general enrollment period is a time every year when you can sign up. There are also various special enrollment periods that apply that can allow folks to enroll in Medicare Part A and B. A lot of these are new. So one that isn't new is if someone loses employer-based coverage based on current active employment, they have a special enrollment period where they can enroll in Medicare Part B. That's been in place for a while. But some new special enrollment periods became available at the beginning of 2023, including a special enrollment period for people who lose Medicaid. So this is huge given the public health emergency. We know that during the COVID public health emergency, people who had Medicaid, for the most part, could not have their Medicaid terminated. And so there were plenty of people who became Medicare eligible and thought, oh, I'm not sure that I can afford to enroll in Medicare at this time. I still have my Medicaid coverage. I'm just not going to enroll in Medicare yet. For those folks, if they lose Medicaid, they get a 6-month special enrollment period to enroll in Medicare Part B. These new special enrollment periods also apply to folks who were formerly incarcerated. There's a special enrollment period for folks who received misinformation from their employer or group health plan, and maybe that's why they didn't enroll in Medicare when they were first eligible. So we've got a link to more information. We previously have done some newsletter articles about these special enrollment periods. I think certainly this is a positive change for the Medicare program to have additional ways for people to enroll if they miss their initial enrollment period. People who do miss their enrollment period are potentially subject to late enrollment penalties, and that's part of why we often encourage folks to enroll when they're first eligible. All right, there are also special enrollment periods for joining a Medicare Advantage plan or joining or changing a Medicare prescription drug plan. So again, during someone's initial enrollment period, they could choose to enroll in a Medicare Advantage plan, or they could choose to enroll in a Part D prescription drug plan. Folks also have the chance to choose to change their health or drug coverage during Medicare's annual open enrollment period, which we are in right now. This happens every fall, October 15th through December 7th, with any changes you make effective January 1st. And so certainly we encourage everyone who has Medicare coverage to review that coverage during their fall open enrollment period and just make sure the coverage they have still works for them. Plans can change year to year. Drug formularies can change, provider networks can change. So it's just a good idea to make sure that the coverage you have is still working for you. We also know prices can change, premiums can change for these plans. So just encouraging folks to take advantage of that annual open enrollment period. There is also a Medicare Advantage open enrollment period every year from January through March. This is an opportunity for people who are in Medicare Advantage plans to either change their plan or choose to go back to original Medicare and enroll in a Part D plan. I think the nice thing about this enrollment period is sometimes people made a choice during their fall open enrollment period. That change goes into effect January 1st, and then they realize, oh shoot, this plan isn't actually going to work for me. Or, oh no, I'm taking a medication that's not covered by my prescription drug plan. So this gives them an opportunity to switch their Medicare Advantage plan if it turns out that the plan they chose is not working for them. And then there's various special enrollment periods throughout the year. The one we like to remind folks about is people who are dual eligible for Medicare and Medicaid, or who are receiving extra help with their prescription drug costs, get a chance to change their Medicare health or drug plan once per quarter during the first 3 quarters of the year. All right, and so we have a link in the materials to a full list of the special enrollment periods and all their rules. Both the ones I talked about on the Part A and B slide, and on this slide, there are different time frames for the various enrollment periods, so you can find more information about those specifics there. So I think this graphic from a training by CMS in the past is really helpful to just provide a visual image of the ways that people can have their Medicare coverage. So as I talked about, people can choose to enroll in, have their Medicare through original Medicare, through the red, white, and blue Medicare card, Part A and B, add a prescription drug plan. They can also have supplemental coverage, a Medigap plan. Medigaps only work with original Medicare. Alternatively, people can choose to enroll in a Medicare Advantage plan that gives them their Part A and B coverage and includes Part D and may include some extra benefits. We know there has been a lot of growth in Medicare Advantage enrollment over the last several years. I think at this point, as of July of 2023, just over half of the Medicare population was enrolled in a Medicare Advantage plan versus having original fee-for-service Medicare. In Pennsylvania, or I have that reversed, I think. Actually, it's just under 50% that are enrolled in Medicare Advantage, just over 50% are in fee-for-service. But in Pennsylvania, it's the reverse. There's more people in Pennsylvania enrolled in Medicare Advantage than are enrolled in fee-for-service Medicare. And we see that especially in western and central parts of Pennsylvania, Medicare Advantage enrollment is really high. So there are just several considerations for people who are making a decision about how to have their Medicare coverage. They need to consider the costs and coverage rules. Some of the potential advantages to Medicare Advantage plans are, one-stop shopping. You don't need to have a separate Medigap. You don't need to have a separate Part D plan. You can have all your coverage through one plan. There's typically additional benefits. Original Medicare does not cover dental care. Many Medicare Advantage plans offer additional benefits such as dental care. They may offer some vision coverage, and people really like those extra benefits. But on the flip side, you're limited to a provider network if you enroll in a Medicare Advantage plan. There's more prior authorization or utilization review than in original Medicare. And it's just challenging to switch back to original Medicare with a Medigap if you choose to enroll in a Medicare Advantage plan. So there's several considerations. At the Health Law Project, we work a lot with the PA-MEDI program, Pennsylvania's state health insurance program that provides free assistance to Medicare beneficiaries who are choosing their Medicare coverage, reviewing their Medicare coverage in the fall, and we certainly encourage people to reach out to PA-MEDI if they need help just reviewing their options. And we have their contact information later in the materials. So just briefly, Medigaps are Medicare supplemental insurance policies. These are sold by private companies. They only work with original Medicare. There are hundreds of options from a variety of insurers, and essentially they fill in the gaps of Medicare. So original Medicare covers 80% generally of people's doctor's visits. And if you have a Medigap plan, that fills in that additional piece, that the additional co-insurance that the individual would have to pay if all they had was original Medicare. The best time to join a Medigap is when you first get Medicare, because you have a Medigap open enrollment period for the first 6 months after you're enrolled in Part B. During that time, plans can't refuse to sell you a policy or can't charge you more based on your health status. After that original open enrollment period, plans can choose to deny coverage or charge more based on health status unless you're protected by a guaranteed issue right. So if you need more information about Medigaps, we have some materials, a link in the materials to more information you can look into. People who have Medicaid cannot be sold Medigap plans because essentially they serve the same purpose. Medicaid is secondary insurance to Medicare. Medigap works in a similar fashion. So people who have full Medicaid generally do not also need to have a Medigap. We did want to flag that right now there is a guaranteed issue opportunity during the Medicaid unwinding. So for people who are losing Medicaid, who maybe did not enroll in a Medigap when it was when they were in that open enrollment period, they can choose to pick up a Medigap. We know we have heard from a lot of folks that they've had trouble using this guaranteed issue opportunity, but it is out there to some extent, and certainly contact PA-MEDI if you're having trouble using that guaranteed issue opportunity. We have a link in the materials to more information about that, and a link to where you can find information about how to file a complaint if you're having difficulty using that Medigap open and guaranteed issue opportunity. Also, people who already have a Medigap who become eligible for Medicaid can choose to suspend their Medigap if they're just feeling like, oh, I'm not sure I want to drop my Medigap, but also I can't really afford to keep paying for it. They can suspend their Medigap for up to 24 months after they first become eligible for Medicaid, and there's more information about how to do that in the materials. So I'm going to stop here and see if we have any questions before I turn it over to Erin.
Yeah, no questions have come through. Someone did note, this goes back to the Part B enrollment rules, that some employers do require people to enroll in Part B and Part A when they're first eligible for it, because the employer plan sometimes pays second to Medicare. And there's a bunch of rules about when Medicare pays first and when they pay second. So some smaller employers will require folks to join Medicare right away because that is primary to the employer plan. Okay, wait, a question just came in. If I have dual eligibility Medicaid and Medicare, do I need Medicare Part D?
Yes, and we'll talk more about this, but once you become eligible for Medicare, Medicaid stops covering your prescriptions. So everyone who has Medicaid and Medicare does have to have a Medicare Part D plan. If you don't choose one, you will be automatically enrolled in one for 0 premium. But we'll talk about that a little bit more in the presentation.
Okay, excellent. Yes, thanks for the questions and comments that have come in. Please continue to do so throughout the training. So now we'll talk about some updates for next year with regard to Medicare. So Medicare costs always typically change year to year. So in recent weeks, Medicare did announce the Part A and Part B cost, as well as Part D costs. And there will be some changes to costs for Medicare coverage between this year and next year. The Part A premium really isn't changing. And again, most people don't pay the Part A premium because they've paid in through their work history or a spouse's work history, or in some cases, a parent's work history. The Part A costs for hospital care are increasing slightly. And then the Part A per day copay for skilled nursing facility coverage under Medicare Part A is also increasing slightly. And Medicare covers the first 20 days of qualifying nursing home stays following a hospitalization at no charge. And then if people need beyond 20 days, there is a per day copay that applies. The Part B premium is increasing slightly for next year, so it'll be $174.70. This is the standard premium, and just to kind of talk through this a little bit, most people who have Medicare Part B will pay the standard premium. Some folks will pay a little bit lower premium, and that's because Medicare, Social Security has this hold harmless provision, so that if the Medicare Part B premium increases to the point where someone's net income from Social Security after the Part B premium is deducted would go down in the following year, like if the cost of living wouldn't increase to cover the increase in the Part B premium, then folks would only have the amount of Part B premium withheld that would keep them at the same net Social Security income into next year. So there might be some people that pay a little bit less than the $174.70 because of that hold harmless protection. Some people with higher incomes pay a higher Part B premium. This is known as IRMA, IRMA, the income related monthly amount. So some people, that have an adjusted gross income, I think the threshold for next year is for single people who have an adjusted gross income of $103,000 a year will pay a higher premium. And then married couples that have a modified adjusted gross income of more than $206,000 will pay a higher premium. And the premium increases based on kind of what your income is over those thresholds. And then some people don't pay any Part B premium if they qualify for Medicaid to pay that through a Medicare savings program or buy-in program. And Katie's going to talk a little bit more about those programs in the next section. The Part B deductible is going up from $226 to $240. So everybody with Medicare Part B pays that deductible at the beginning of the year, or, kind of whenever they start to get services during the year, and then Medicare pays 80% of the services after that, and people have a 20% coinsurance that either they pay or a Medigap plan pays or Medicaid pays if somebody is a dual eligible. And then if somebody's in Part C or Part D, then those plans decide what premiums to charge, the deductibles to charge, coinsurance, copays. But if somebody joins a Medicare Advantage plan for their health coverage, as opposed to original or traditional Medicare, they still do have to pay the Part B premium. and any Part A premium that might apply to them, because someone has to have both Part A and Part B to join a Medicare Advantage plan. Okay, next slide. Okay, so every year Medicare sets the cost sharing for the Part D standard drug benefit. Most plans don't follow this exactly. They structure their benefits a little bit differently, but in the end, the cost for coverage is actuarially equivalent to the Part D standard drug benefit that Medicare establishes. So next year, the national base beneficiary premium is $34.70. In Pennsylvania, you know, the premiums will vary by plan, but next year for the choices available to Pennsylvania residents, the lowest premium is 50 cents a month and the highest premium is almost $200 a month. The big change regarding coverage, in addition to the increases for the deductibles and kind of the out-of-pocket thresholds, is that next year for people that reach this catastrophic coverage phase, they will not have any cost sharing for the rest of the year if they hit that phase. So that's a big change. And that was part of the Inflation Reduction Act changes that are taking effect. And this one takes effect next year. So again, most plans, you know, plans may not have a deductible, but if they do have a deductible, it is capped at $545. Most plans do a tiered copay structure as opposed to this initial coverage period where people pay 25%. So again, most plans maybe have generic drugs on a lower tier, tier 1 or tier 2, where maybe there's no copay for tier 1 drugs, a small copay for tier 2 drugs, and then brand name drugs are on a tier 3 or 4 with some higher copays for those medications. And while the coverage gap went away for people that have been around for a while, you all might remember that the coverage gap used to be really significant for people because they were responsible for 100% of their drug charges during that coverage gap. So over the past several years, the coverage gap has closed, and essentially there is no coverage gap anymore. People pay 25%, the same as in the initial coverage period. But because of that, of how the plans structure their benefits, and because most plans use that tiered copay structure, people will see an increase to the cost that they pay for their drugs when they enter what's known as the coverage gap phase, because they will be charged the 25% in that phase as opposed to the tiered copays that they were paying previously. Okay, next slide. Okay, so Medicare did announce the plan options available for next year, and people in Pennsylvania continue to have a number of options. If people get the Medicare and You handbook, all of the plan options available next year are listed kind of at the back of the book for people in Pennsylvania. There are 21 standalone prescription drug plans that work with folks that have original Medicare. So this is a little bit fewer choices. I think there are 26 PDPs this year, going down to 21 next year. There will be 5 zero premium plans for dual eligibles and people with the extra help. That's down from 7 this year. We're going to talk a little bit more about the zero premium plans in just a minute. Again, Katie said, you know, Medicare Advantage plans continue to grow. They continue to be popular choices among Medicare beneficiaries. And there are a number of choices available in each county for Medicare Advantage plan options. I think Pike County has the fewest options with 37. That's still a lot of plan choices. And then Northampton and Lehigh counties have the most plan options available with 83 plans. So I think we all can appreciate just how challenging it is to compare 83 plans or even 37 plans to try to figure out which plan might be best for somebody. And again, that's where PA Medi counselors can be really helpful in helping people sort through their choices available. And then there are a subset of Medicare Advantage plans that are called special needs plans. These special needs plans option vary county by county. And special needs plans just limit their enrollment to certain groups of people with Medicare. So there are dual special needs plans that require people to have some level of Medicaid coverage to be able to join a dual special needs plan. There are institutional special needs plans that require people to live in institutions to be able to join the plan. And then there are some limited chronic condition special needs plans in Pennsylvania. And there are some available in some counties. And these are typically geared towards people with cardiovascular disease, chronic heart failure, or diabetes. Next slide, please. Okay, so just to spend some time talking about some zero premium plan updates that we wanted to flag for folks. So right now, Elixir is a Part D plan sponsor that has two plan options available in Pennsylvania. One of them is a zero premium plan. So next year, Elixir is not offering any Part D plans in Pennsylvania and possibly around the country. So what this means then is for somebody in Elixir this year that has extra help, if that individual member does not make a different choice by the end of the year, Medicare will reassign them to a different zero premium plan, and we'll be sending folks a reassignment notice that comes on blue paper. For Humana, for the last several years, Humana has offered a zero premium plan option. The Humana RX Basic is that zero premium plan option this year. Next year, Humana will not offer a zero premium plan. So the Humana RX Basic plan will still be available next year, but it will not be zero premium for people that have extra help. So it's a little bit confusing about what's going to happen to folks with extra help who have this Humana RX Basic plan this year. If Medicare assigned somebody or auto-enrolled somebody into that Humana RX Basic plan, and if the person who was auto-enrolled into that plan doesn't make a different choice on their own, Medicare will reassign them to a different zero premium plan and will send a blue reassignment notice telling them what plan they'll be reassigned to for next year. If somebody with extra help chose to enroll in Humana, these folks will get what's called a chooser notice that comes on kind of tan or beige paper. And that notice will tell people that they can make a different choice, that they can pick a different plan to avoid a premium next year. But if they stay in the plan, they will have a premium that will be $5.10 for people getting extra help next year. And then the last thing we wanted to highlight regarding zero premium plans is that one of the 5 options available next year, it's available this year as well as a zero premium plan. They're currently under sanctions, and they could be terminated at the end of next year, depending on whether the plan appeals the sanction. But they're sanctioned because they haven't met quality measures that Medicare has outlined, so they're considered out of compliance with Medicare's quality measures. There's probably some other issues that are resulting in this sanction. But as a result of the sanction, ClearSpring Value RX cannot market their plan to people. They can't enroll people. So nobody should be auto-enrolled or reassigned to ClearSpring Value RX for next year. It does not show up. It will not show up in the Medicare.gov plan finder as an option. But certainly people, are probably enrolled in that plan for this year, and folks that have the plan may want to look at switching to a different zero premium plan for next year because of these quality concerns. So just wanted to highlight those changes for the zero premium plans. Okay, just to talk briefly about dual eligible special needs plans. Again, these are the subset of plans for people that have Medicare and Medicaid. Typically, people must have full Medicaid to join, but there are some plans that do allow partial dual eligibles to join their plan. Partial dual eligibles are people that get some level of Medicaid, but don't get full coverage through Medicaid. So examples of partial dual eligibles are people that only get the Part B premium paid for by Medicaid, people that are just in the buy-in program only. Some people on Medicaid who also have Medicare, get help with the Part B premium, and then Medicaid just covers the Medicare cost sharing. They don't get any other benefits through Medicaid. So those are examples of some partial dual eligibles. Every year, I think if you've joined this webinar before, we always remind folks that the dual special needs plans only provide somebody's Medicare coverage. It's a Medicare plan. People have Medicaid that is second and separate to the D-SNP coverage. We don't have any fully integrated dual special needs plans in Pennsylvania. All of the D-SNP plans are generally zero premium. Because someone has to be a dual eligible, they all automatically get extra help. And then every county next year has D-SNP options. I think everybody has at least 7 D-SNP plans available to them. And there didn't seem to be any major changes in terms of D-SNP companies going away or new D-SNP companies coming in with new plans for next year. Next slide, please. Okay, so just wanted to kind of highlight some Medicare Advantage changes that apply to plans for next year. Folks might have seen that the Office of Inspector General was looking into Medicare Advantage denials. There's been some more focus on just kind of how Medicare Advantage plans kind of restrict people's access to benefits or may deny services that end up being overturned and found medically necessary through the appeals process. So as a result of some of these investigations or reports, Medicare put some additional requirements on Medicare Advantage plans for next year. There are requirements related to prior authorization that Medicare Advantage plans have to follow. And this is basically to help ensure that Medicare Advantage enrollees get the same access to medically necessary services that they would get if they had coverage through the original Medicare program. So to highlight just some of the changes, plans have to keep the prior authorization valid for as long as medically necessary to complete the course of treatment that got prior authorized or to complete the test that got prior authorized. They can't have really short windows for the prior authorization approval. Plans have to review their utilization management policies every year to make sure that they are still applicable or see if they need to be revised at all. And then prior to issuing a denial notice for a service, that denial decision has to be reviewed by a healthcare professional with relevant expertise if the denial is because the company is finding that the service isn't medically necessary. So it's just an additional check to try to make sure that denials are appropriate and aren't just a barrier to folks getting coverage for services that they need. Another change is regarding contract terminations for primary care physicians or behavioral health providers. There are notice requirements for any contract termination with a provider. Typically, people have to get 30 days notice if their provider has a contract that will be terminated with the managed care plan. But for primary care providers and behavioral health providers now, there is a 45-day notice requirement. People have to get a written notice in the mail, and they have to have one phone call attempt by the managed care plan to let them know about the contract termination. Affected enrollees include people that are currently assigned to the primary care provider, as well as patients who have seen that primary care provider or behavioral health provider within the last 3 years. That's who would be getting notice about any contract termination for these types of providers. Okay, a big change, and we're going to talk more about extra help in the next section, but a big change for next year is that partial extra help is going away and the full extra help program is expanding. So since extra help started back in 2006 when Medicare Part D started, there have been 2 levels of extra help. There's been full and partial extra help. Most people who qualify for extra help, 97% of them have gotten full extra help, but a small percentage of people have been getting partial extra help. So pretty much partial extra help's going away. There'll be 1 level of extra help. Everybody who qualifies for extra help will get the full amount of extra help starting next year. So anybody getting partial extra help now will automatically be converted to full extra help. They don't need to do anything special for that to happen. So that's a really promising change. And again, Katie's going to talk a little bit more about extra help in the next section. Okay, just a quick update about the LINET program. This is a temporary prescription program for people with extra help that don't have any Part D coverage initially at the beginning of when they might transition to dual eligibility or when they initially get extra help. So it's called LINET. Some people might call it LINET. For folks that have been on this training before, I always give an anecdote that someone called asking for Lynette, and it took me way longer than it should have to realize they were talking about this program and not looking for a person named Lynette. So this program provides kind of immediate Part D coverage to people with extra help, and it can also provide retroactive coverage if needed for people to get reimbursed for medications that they might have paid for out of pocket before they realized that this was available. This has been around since 2010. It's been a demonstration program all these years. So the change for next year is that this is a permanent program starting next year and will be part of the Part D program moving forward. Humana currently administers the LINET program, and there's the phone number there and also a website with some resources about it. We're going to walk through an example of a recent client that we helped use LINET just to kind of help people understand why it may be beneficial, because it's been around for a while, but people still don't necessarily know about it or think about it when somebody you might be working with or you yourself might be a new dual eligible and having problems getting prescriptions covered. Okay, sorry, Katie, this is an animated slide. So Kate became a new dual eligible as of September 1st of this year. And she was unable to get her medications that month because her Medicaid drug coverage stopped because Medicaid will stop covering drugs, as Katie mentioned earlier. And Kate wasn't yet enrolled in a Part D plan. So we talked to Kate, we contacted LINET with her. Sometimes they can see that somebody has Medicaid coverage, and that's a much easier process. They can typically, give information for the pharmacy to bill LINET if they can see that somebody has Medicaid. In Kate's case, for some reason, they couldn't see that she had Medicaid, so there was another step that we had to go through for LINET to be able to cover her prescriptions. Because she was needing prescriptions that day, we had to ask for what's called an immediate need override. LINET contacted the pharmacy to give the pharmacy overrides for each of Kate's medications. And then they went through. Kate only paid small extra help copays for those prescriptions. We had to fax proof of Medicaid to LINET just so that they could have that proof that Kate was covered by the Medicaid program. Kate stayed in LINET for her drug coverage for September and October, and then Medicare ended up auto-enrolling her into a different zero premium drug plan for coverage starting in November. So again, this is just a really great program for people to use temporarily until they get connected with some other coverage and until their extra help information gets updated. So anybody could kind of do the same thing that we did to help Kate. People can contact LINET themselves or an advocate can call them to get things rolling to use that coverage. The only thing to be aware of is if somebody's in a Medicare Advantage plan, LINET will not work, even if that Medicare Advantage plan doesn't include prescription coverage. LINET is for people in original Medicare who do not yet have any Part D coverage, and they either have extra help or they should be having extra help because they are a dual eligible. Okay. There are some changes to Medicare's coverage. We just wanted to flag a couple of these. There's a link to more Medicare coverage updates for next year. But starting next year, Medicare will cover services that are provided by mental health counselors and marriage and family therapists that are enrolled in Medicare. So it's not clear if this is going to really help duals or people that have Medicare and Medicaid be able to access mental health care more easily. We're hoping it does because it's going to expand the pool of available Medicare providers for mental health services. But we'll all have to see practically how this change plays out in terms of whether it really helps people access services. And then they're expanding coverage of some of their what they're calling intensive outpatient programs. So some mobile mental health, crisis services, some more just intensive services between kind of the once a week therapy, once every couple weeks therapy, and inpatient mental health services. There are some additional services between those two options that will be available under Medicare next year. So even though we are not in the COVID public health emergency anymore, obviously people still are getting COVID, still dealing with maybe some effects of COVID, but we just wanted to make sure people were aware that Medicare will continue to cover COVID vaccines next year. They will continue to cover treatment for COVID when certain criteria are met. And if a provider orders lab tests for COVID to test to see if somebody has it, those will be covered, but over-the-counter tests will no longer be covered by Medicare next year. And Medicare does cover vaccines like shingles vaccines, the RSV vaccine, some other vaccines. So people should be checking with their Part D plan about what vaccines are covered for next year. Okay, as a reminder, this year Medicare started covering certain insulins for $35 a month. The big change is that now the insulin costs on the Medicare Plan Finder on Medicare.gov are updated. Last open enrollment season, they were not. So that just made it more challenging for people to compare coverage. But everything is updated for this year, and the covered insulins that the $35 copay applies for should show up that way on Medicare.gov now. And this is most important for people that don't get extra help. Okay, Medicare continues to have their plan finder on Medicare.gov. Anybody can use it. You have to create an account to be able to save your drug list, to see your personalized information, and you don't need an email address to create an account. If somebody has created an account, then they'll be able to kind of go in and see what their coverage is, see if they have extra help. And the next couple slides are just examples of kind of how that would look if you have an account on Medicare.gov. So the first slide, and I know these are probably hard to see, but this particular person has a Medigap plan, so you can see that that's listed there. They don't have extra help, so where the blue arrow is, if you can see that, shows that this person does not have any extra help. On the next slide is an example of what a dual eligible's coverage should look like, although it doesn't show that they have Medicaid coverage, and typically it does. But you can see here, this person, the extra help is showing up for this year and next year by that blue arrow toward the end of the slide, toward the bottom of the slide, if you can see that. Okay, just a couple more updates before we'll stop for questions. Over the last several years, Medicare has paid a lot of attention to marketing and communication, being especially mindful of some predatory television ads. And this is kudos to the PA Medi program and other state health insurance programs, as well as the Senior Medicare Patrol programs that really have continued to raise concerns about some of the marketing tactics that plans are using to get people to enroll. That led to Medicare updating and strengthening some protections. There have to be disclaimers now on ads, letting people know about Medicare, letting people know to contact their state health insurance program for more information. The big thing to keep in mind is that Medicare beneficiaries should not have anybody coming door to door to market plans to them or to enroll or to try to get people to enroll in plans. So no door-to-door contact is allowed. People should be getting notices every year that they can opt out of phone calls and other marketing from their insurance company. There are timeframes that are put in place so that if somebody schedules an appointment, the meeting cannot happen until 48 hours after the appointment is scheduled. For educational events, they cannot immediately follow that educational event with a marketing event. They have to have 12 hours between educational events and marketing events in the same location. And then there are some requirements related to summary of benefits so that the services have to be listed in the same specific order, and they have to kind of be at the top of a plan summary of benefits to make comparisons plan by plan easier. So if anybody has concerns about questionable marketing or enrollment practices, please reach out to PA Medi. The Senior Medicare Patrol in Pennsylvania is through Carrie. And as a reminder, if somebody kind of enrolled in a plan under false pretenses, being told, oh yeah, your doctor's covered when they aren't covered, or yes, this plan will cover all your prescriptions, and then the person enrolls in it only to find out that there are prescriptions not covered by the plan, that can be a grounds for a special enrollment period, and you have to call Medicare to request that. Okay, this slide just has some changes to look forward to in upcoming years for people that might be interested. And of course, our next webinar next year, we'll talk about these changes as we get closer to them. But there are some upcoming changes in following years that people should be aware of related to caps on out-of-pocket costs and negotiated drug prices for 10 drugs that will start in 2026. Okay, I know that was a lot of information. I think we've had some questions come through, so I'll stop here and we'll take some questions before turning it over to Katie.
All right. Yes, we had a question about, I think this refers to the Part D costs that you covered. In 2025, people will be allowed to spread their out-of-pocket costs over the course of the year. Why that's not available in 2024, and I think that's just one of the Inflation Reduction Act changes. The Part D changes kind of go into effect over a series of years. Is that right?
Yes. Yep.
And then we also got a comment that the Clear Spring plan you talked about that has sanctions is showing up in the plan finder, but with a warning.
Okay.
So that's
so maybe for
different. Yeah.
Yeah, I think for 2024, when I checked, it wasn't showing up. You had to click see sanction plans, but maybe it is showing up for 2023. Or maybe something changed since I looked at it. So thanks for that clarification.
All right. And then we had a question, a disabled adult child now covered under parents' work insurance and only has Medicare Part A. Will there be a penalty if the disabled adult child chooses to no longer be covered under the parent's employer provided plan and signs up for Medicare Part B? This is a pretty specific question. Margaret, who asked that question, you might want to reach out to us directly, but there are some, depending on if the disabled adult child is considered a disabled adult child for Medicaid purposes as well as Social Security purposes, they may be able to enroll in Part B with a buy-in, but maybe reach out to us about that, unless Erin, you want to talk any more about that question.
Yeah, there are lots of nuances to this employer, kind of who can delay Part B based on employer coverage and avoid a penalty. It has to do with whether someone's a current active employee. So I think it's best, yeah, let's talk through, reach out to Katie or I after the training. Our contact information will be on the last slide, just so we don't give you wrong information. We would like to kind of hear the details of it so we can give you accurate information.
And then there was a question, can you explain the Part B increase if the Social Security COLA is lower than the increase? I think that was something you went over earlier.
Yeah. So let's say the COLA is only increasing somebody's monthly income by $8, right? The premium's going up by about $10. So they'll be charged a lower Part B premium so that their net Social Security income doesn't go down between 2023 and 2024. So the Part B premium should never cause somebody's net Social Security income to be lower the following year than it is currently. So I don't know, maybe that doesn't help clarify things, but that's kind of what it is. That if someone's cost of living adjustment increase would not cover the whole increase to the Part B premium, the Part B premium will not go up to 174. It'll be some amount between this year's premium and next year's premium to keep them at the same income level, at least this year to next year, net from Social Security.
All right, thanks, Erin.
Yeah, is that everything? Okay.
That's it.
All right.
Okay, let's talk now about programs that help with Medicare costs. So we've just heard from Erin about Medicare coverage, and Medicare is great coverage, but it is expensive. We just heard all these different costs. Everyone has to pay a Part B premium. That is expensive. There are copays and coinsurance involved in Medicare. And we know that poverty is pervasive in Medicare. And that's why we wanted to share this graphic, just showing that there are a whole lot of Medicare beneficiaries who have low income. And so it can be a challenge to afford their Medicare costs. We know that the Medicare savings programs, one of the programs we are going to talk about, are underutilized, and that there are more people eligible than are enrolled. There was a recent survey by the Commonwealth Fund that was published in September that found that many Medicare beneficiaries are really struggling with their costs and at times are going without care because of the costs of Medicare. So how can we help these folks? So these are the programs we're going to talk about. We're going to go over 3 programs that help with Medicare costs. The Medicare Savings Program, also called the Buy-In Program in Pennsylvania. The primary benefit of this program is it helps people pay their Medicare Part B premium. And then we're going to talk about Extra Help and PACE and PACENet programs, which help with people's prescription drug costs. And I think these programs are especially important to remember as we hear from people who are terminated from Medicaid as we're going through the unwinding of the COVID public health emergency protections. We do have links here on this slide. PHLP puts out an updated fact sheet every year on the Medicare savings programs and the Extra Help program with more information. PACE and PACENet has a very useful website. This is a super easy program to apply for, and there's a link in the materials to their website if you want to learn more. So let's start with the Medicare Savings Program. This is a Medicaid program. As I mentioned, it's also called the Buy-In Program, and that's primarily how the county assistance offices refer to it. It is a Medicaid program that helps people pay their Medicare Part A and B costs. So the primary benefit of this program is coverage of the Part B premium. Most people don't pay a premium for their Part A because they have enough quarters of coverage, or their partner or spouse has enough quarters of coverage to enable them to get Medicare Part A for free. But everyone has to pay a Medicare Part B premium unless they qualify for this program where the state can pay your Part B premium for you. For people with very low income, the Medicare Savings Program can also cover the Part A premium if someone doesn't qualify for free Part A, and can also cover Medicare deductibles and copays. There are a couple different levels of the Medicare Savings Program. We're not going to get into the weeds with this program, but just know that it helps people pay their Part B premium. The other really significant benefit of the Medicare Savings Program is it can help people get enrolled in Part B with no late enrollment penalty. So people who qualify for the Medicare Savings Program don't have to wait until the general enrollment period to enroll in Part B. They can enroll at any time through this program, and any late enrollment penalty that they have is eliminated. Even if later down the road they stop qualifying for this program, enrollment in the Medicare Savings Program makes that late enrollment penalty go away. So that is a huge benefit. And so if you're working with someone who maybe doesn't have Medicare Part B and needs it, it's definitely worth checking to see if they qualify for the Medicare Savings Program. So why are these programs important? The Medicare Part B premium is almost $165 in 2023. It's going up to around $175 next year. So most people who are on Medicare, their Medicare Part B premium comes directly out of their Social Security check. This gives them that money back in their check so they can use it to pay for their rent or their medications or
food, we all know that food is expensive. So getting the Medicare Savings Program helps people because they have more income to use for their other needs. And it also, if someone is enrolled in the Medicare Savings Program, they automatically qualify for extra help with their prescription drug costs. And we'll talk more about that. But we know that a lot of people don't know about this program or might need help applying. Often we'll hear from people who have had a change in circumstances. Maybe they didn't used to be eligible for this program, but now they've stopped working. Maybe their spouse has passed away, or maybe they've spent down their savings and now qualify for this program, and it can be a huge benefit to them. So to enroll in the Medicare Savings Program, you have to meet the income and resource limits for that program, and you also have to either have Medicare Part B already or be eligible for it. The income limits and are adjusted for inflation and increase each year based on the federal poverty levels. So just stay tuned for that. We will release as soon as we get that information, usually around February. We'll put out a newsletter article and update our fact sheet to reflect the new income limits for this program. This year, the resource limits for this program are listed here for single and married folks. For the last many years, the resource limits for the Medicare Savings Program were tied to the extra help resource limits. That is ending this year. So we're not sure what's going to happen exactly with the resource limits. We assume that they will continue to change a little bit over time, but because of the expansion of the extra help program, the Medicare Savings Program resource limits are no longer tied directly to the extra help resource limits. So another thing to stay tuned for, I'm sure we will be doing advocacy around that to encourage Pennsylvania to try to align the resource limits for extra help in the Medicare savings programs. So these are the upper limits, the upper income limits for the Medicare savings programs. Not all income and resources count toward these limits. So for example, if someone is working, only about half of their earned income counts toward these income limits. If someone owns their own home, that does not count as a resource for this resource limit. If they own one car does not count. So if someone seems close to these limits or is really struggling with their Medicare costs, it's worth reviewing them to see if they might be eligible. Applying for the Medicare Savings Program, you can do through Compass. But that requires you to do the full Medicaid application. There is also a link here to the PA 600M form, which is an application just for the Medicare Savings Program. Generally, if we know that someone is eligible just for this help, we recommend that they do the paper application just because it's a little shorter and easier. You submit the completed application and attach verification documents and give that to the county assistance office. You can call the customer service center to follow up to make sure they received your application, see if any additional information is needed. You can apply for this program at any time. The county assistance office will reach out and let you know if they need additional information, and you should get a decision about your eligibility within 30 to 45 days. If someone is denied eligibility for this program, they have a right to file an appeal. And if someone is approved for the program, within a month or so, the Part B premiums should stop coming out of their Social Security check, and any premiums they paid since the Medicare Savings Program start date should be refunded to them. That comes directly from Social Security. So every now and then we see people who are for some reason it doesn't kick in, and it's worth reaching back out to the county assistance office if you're hear that you're approved for this program and your Part B premium keeps coming out of your check. Most people who are in the Medicare Savings Program, as I mentioned, get help with their Part B premium, but there is also a Part A buy-in program for people with very low incomes, people on SSI, or below 100% of the federal poverty level. Just flagging this because we see sometimes that the Part B buy-in happens, but not the Part A buy-in. And so people are left with, they have Medicare Part B, but not Medicare Part A. If someone is in this situation and already has Medicaid, typically these folks do have Medicaid, have them reach out to the county assistance office and specifically ask to be reviewed for the Part A buy-in. Once it goes through, they should get a new Medicare card showing their Medicare Part A and B start date. We know that the Department of Human Services is doing data sweeps to try to catch people and enroll folks who should be enrolled in the Part A buy-in, but we're still getting calls from people who have not gotten Part A. People who have Medicaid already have full coverage, so even though they don't have Medicare Part A yet, they still have full coverage. If they had to go to the hospital, they have their Medicaid coverage to cover that. But for a lot of people, they want to enroll in a Medicare Advantage plan. You can't enroll in a Medicare Advantage plan, as Erin mentioned, unless you have Medicare Part A and B. Medicaid is supposed to be the payer of last resort, so really these folks should be enrolled in the buy-in. So anyway, just flagging because we have seen plenty of people who did not get this coverage. And we have a quick example here. So Elaine is 68 years old. She's on SSI and has Medicare Part B and has Medicaid through a Community Health Choices plan. She doesn't have enough quarters of work to get Medicare Part A for free. She should contact the county assistance office or the customer service center and ask to be reviewed for the Part A buy-in. The county assistance office should enter the Part A buy-in code, which is sent to Social Security. As long as the information between the county assistance office and Social Security match, Pennsylvania's Medicaid program will start paying the Part A premium and Social Security will enroll her in Part A. She'll get her new Medicare card showing her Part A and Part B start dates. And her Medicaid will continue to cover any hospital care she needs until she gets Medicare Part A. And this is based on a recent case we had. So just sharing this information. All right, so that's the Medicare Savings Program. Just a quick overview. Now I want to talk a little bit about Extra Help. So Extra Help is a Medicare program. As Erin mentioned, starting in January, everyone who qualifies for Extra Help gets full Extra Help. This is a fantastic change that will really help people. The Extra Help program helps with Medicare Part D costs by lowering the premiums, deductibles, and copays, and also people who are eligible for Extra Help. This eliminates any late enrollment penalty they might have if they didn't enroll in Medicare Part D when they were first eligible. People apply through Social Security, and then it is administered through CMS. Much like the Medicare Savings Program, the Medicare Part D prescription drug program can be costly. So the Extra Help program is important because it helps people have more money for their other needs. It was created along with Medicare Part D to help people with limited incomes and resources afford Part D. But we know that not everyone who is eligible for this program gets this help. So we want to encourage folks to check with people. Do you have help with your prescription drug costs? If not, see if they might qualify for the Extra Help program. People who get full Extra Help in 2024 will receive premium subsidy up to $40.16. As Erin mentioned, there are 5 Part D plans that are 0 premium plans for people with Extra Help. If they choose to enroll in any of those plans, they will have 0 premium for 2024. But if people choose to enroll in a different Part D plan, they'll have, they can get help with the premium for that plan up to $40.16 a month. Folks who have Extra Help don't have to pay a deductible. Their copays are limited if they're in a long-term care Medicaid situation where they're getting waiver services or are in a nursing home, they have 0 copays. People who are below 100% of the federal poverty level have lower copays, and then people above 100% of the federal poverty level have slightly higher copays. But these are much more limited copays than someone would typically be paying if they're just in a Part D plan without extra help. And at a certain point in the year, if someone's out-of-pocket costs plus the extra help payments reach $8,000, they may have to pay no copays at all for the remainder of the year. So after seeing Erin's slide about the Part D costs, you can see what a huge benefit the extra help program is. So how do people qualify for extra help? If you are on Medicaid or receiving any Medicaid benefit, you automatically qualify for extra help. You do not need to apply. Even if the only help you're getting through Medicaid is help with your Medicare Part B premium, you qualify for extra help and you're done. Other folks do need to apply. Social Security processes those applications, and you have to meet the income and resource limits for the extra help program. So these are the resource limits for 2024. We already know what the resource limits will be for 2024. So this is a huge jump in the resource limits for full extra help because of the expansion of the extra help program. Now people with higher resources will be able to access extra help and get the full benefit. The monthly income limit we have listed here is 150% of the federal poverty level for 2023. Just like the Medicare Savings Program, we'll know the new income limits for this program for 2024 early in 2024, and we will update folks when we get that information. So much like with the Medicare Savings Program, not all income and resources count. The resource limit builds in a $1,500 per person disregard if the person indicates on their application that they plan to use their resources toward funeral or burial expenses. Again, if someone is working, only about half of their earned income counts toward these limits. Cars don't count toward extra help. Life insurance doesn't count as a resource. So if someone seems close to these limits or is having trouble affording their prescription drug costs, it's worth seeing if they might qualify for this program. You can apply at any time. You don't need to already have Medicare Part D. If you are approved for extra help, that will enroll you in Medicare Part D. And you need to apply through Social Security. Really, the easiest way to apply for extra help is to do it online. You can also call, you can mail in a paper application, but you have to go get an original paper application from your local Social Security office, which is why generally it's easier to just do online. So just as a reminder, I know we always drill this in, but anyone who gets any Medicaid benefit gets extra help. They do not need to apply. One of the nice things about the extra help program is once you're approved for the entire calendar year. If you're on Medicaid at any time between July and December, you're also automatically approved for all of the next year too. So sometimes people are anxious when they are being terminated from Medicaid that they're also going to lose their extra help. So extra help stays in place even after you're terminated from Medicaid. If someone was terminated from Medicaid before July 1st, they would still have their extra help coverage for all of 2023. If someone loses their Medicaid after July 1st, they would already have been approved for extra help for all of 2024 as well. But people who aren't sure if they have extra help can check their status on Medicare.gov if they've created an account, or they can call 1-800-Medicare to check their status. So just to see how well we've done training you on this topic, we wanted to launch a few polls about the extra help program. So the first question, Rita loses Medicaid in June of 2023. When does Rita's extra help end? And we'll give you a minute to answer. I can see the answers are still coming in. All right. So those of you who said December 2023 have it correct. So because Rita is losing her Medicaid before July 1st, she has her extra help in place for the rest of 2023. But if she hasn't regained Medicaid eligibility, she will need to apply if she wants to keep extra helps. She'll need to apply for the extra help program and see if she remains eligible in 2024. Okay, and now the next question. Justin loses Medicaid in September of 2023. When does Justin's extra help end? All right, and I see answers rolling in. It looks like most of you have this figured out. Justin's extra help will not end until the end of 2024. So because he's losing his Medicaid after July 1st, he has already been deemed eligible for extra help for all of 2024. So the nice thing about the extra help program, they're checking someone's Medicaid status and deeming people eligible around the 1st of July. If someone has Medicaid at that time, they're deemed eligible for all of the following year. So Justin would have even though he's losing his Medicaid in September of 2023, he'll have his extra help for all of 2023 and all of 2024 also. And at that point, if he's not regained his Medicaid eligibility, he can apply for the extra help program. All right, thank you for indulging us in doing those polls. Erin mentioned some of these mailings that go to Medicare beneficiaries. If people no longer automatically qualify for help in 2024, like Rita in that last example, she should get something, a loss of deemed status letter, notifying her that she no longer automatically qualifies for extra help. And she'll get an application so that she can apply and see if she meets the income and resource limits. If someone's copay level is changing, they'll get a mailing. Once you're approved for extra help, for people who apply for extra help, once they're approved, their coverage just stays in place unless they get a redetermination letter from Social Security. So every year, Social Security chooses a certain number of people to review for continued extra help eligibility. If you're chosen, you get redetermination paperwork sent in September that must be completed and returned. If that renewal is not completed, the person's extra help eligibility will end. And then, you know, as we've mentioned, thanks to the Inflation Reduction Act, the extra help program is expanding. So people who had partial extra help should be receiving a letter letting them know that they will have full extra help in 2024 and just explaining the increased assistance they will receive. The last program I wanted to go over briefly is the PACE and PACENet program. This is a Pennsylvania program. It is a prescription program for older adults with limited incomes. People who have full Medicaid are not eligible for this program. But if you have just help through the Medicare Savings Program, you can also apply for the PACE and PACENet program. We have on here the income and resource limits to qualify for these programs. PACE is for folks with lower income. PACENet is for folks with slightly higher incomes. The benefit is a little bit different depending on which program you're in. But there is no asset test for this program. So it's a really good program for people who are over the asset limit to qualify for extra help. This is a way that they can still get help with their prescription drug costs. And let's see. Yeah, they look at your previous year's income when you apply. You can apply at any time. They don't count as part of your income any amount you pay for your Part B premium. Applications are turned around really quickly. And it's very easy to apply on the website. You can apply by phone. You can fax in an application. The application is very short. And again, they turn around those very quickly. I think that's probably it for that program. And let me see, do we have any questions at this point, Erin?
No, just the question I think that you said to hold off on, and I think we'll talk a little bit more about that in this section. So we'll come back to it.
Okay, sounds good.
No, you did a great job. So no questions, no questions. All right, so we're going to just spend, we're going to quickly review just kind of the basics of dual eligibilities before I turn it back to Katie to talk about the PHE unwinding highlights. So again, we know that this is a training about Medicare, but we, you know, Katie and I deal every day with people that have Medicare and Medicaid, and that population is called dual eligibles. So we just kind of wanted to run through some basics about this because we know a lot of you all work with them with dual eligibles as well, or you might be a dual eligible or be a family member of a dual eligible. So just to quickly remind folks about what Medicaid is. Medicaid is another big health program, but it's different from Medicare. In Pennsylvania, the Medicaid program is run by the Pennsylvania Department of Human Services. We call our Medicaid program medical assistance in Pennsylvania. So if you see MA, it could mean medical assistance. It could also mean Medicare Advantage. Some of the problem is that the terminology, there's multiple terminologies for these different programs, and sometimes the terminology overlaps. But over 84 million people in the US rely on Medicaid, and in Pennsylvania, about 1 in 4 Pennsylvanians, 3.5 million Pennsylvanians rely on Medicaid. It's a really important program, and chances are, you know, you have a family member, a neighbor, a friend, somebody you interact with in your community, just your, you know, Medicaid is really important, and a lot of people rely on this. It can be somebody's only health insurance program, or it can be secondary to other coverage like Medicare. And you have to meet different eligibility criteria to qualify for Medicare. And there's a bunch of different ways people can qualify for the Medicaid program. We're not going to get into the eligibility piece of it, but when I emailed out the handouts, one of the links was just to the income and resource limits for the various Medicaid programs. That will hopefully be a good resource for everybody. Okay, so why do we talk about dual eligibility? Why do we think it's important? Pennsylvania has a lot of dual eligibles. So about over 500,000 people on Medicaid in Pennsylvania also have Medicare. Most people who are dual eligibles get full Medicaid coverage, so they get the full Medicaid benefits in addition to help with Medicare cost sharing. Dual eligibles have really good coverage between Medicare and Medicaid. They have comprehensive coverage, but these are two big health insurance programs that are different programs. So we all can appreciate that coordinating the benefits, kind of navigating these two systems can be really challenging for people. And dual eligibles tend to be sicker than other Medicare or Medicaid beneficiaries, and they cost the Medicaid program, you know, they're a high cost population for both the Medicare and the Medicaid programs. And then there are certain protections that apply that we'll just kind of highlight quickly today. Okay, so this slide just kind of gives some basics of coverage for full dual eligibles. So Medicare is always the primary insurance for dual eligibles. It's what's going to pay first for most healthcare services, hospitalizations, doctor's visits, lab work, surgeries people need. And then all dual eligibles must get their prescription coverage through Medicare Part D. So everybody who's a dual has to be in Medicare Part D. They automatically get extra help. And then there's some billing protections that apply to some dual eligibles on the Medicare side of services. Medicaid, again, is second and separate coverage. Medicaid will pay the Medicare Part A and B deductibles. It should cover the coinsurance and copays that apply. it's important to keep in mind that if somebody is a dual eligible, they may or may not get help with the payment of the Part B premium. So there's certain criteria that people have to meet in terms of income and resource limits for people to qualify for the help with the Part B premium, in addition to other Medicaid coverage that somebody might qualify for. And this is hard for people to understand, and I know we get a lot of questions about that. Everybody on Medicaid who gets full coverage through Medicaid gets the adult benefit package. So this includes dental care, it includes eye exams, it includes incontinence supplies. So for people that need adult diapers, they can get that through Medicaid. Medicare doesn't cover that. Medicaid covers over-the-counter medications, some over-the-counter medications. Medicare does not cover over-the-counter medications unless you're in a Medicare Advantage plan, and that plan offers the over-the-counter coverage as an extra benefit. And then there are billing protections that apply on the Medicaid side of coverage. You know, providers can only charge people the small Medicaid copay that applies to a service. And sometimes for many duals, there is no copay for services if they're in, especially if they're in community health choices. Okay, so we talked through this, but pretty much dual eligibles get their prescription coverage through Medicare Part D. Medicaid will pay second to Part A and B covered services. It does not pay second to Part D. So dual eligibles with their extra help are going to have those different copays that Katie talked about. Some duals who get waivers or in nursing homes and on Medicaid, they won't have a copay with their extra help. Other people will pay either the lower level copay or the higher level copay. But dual eligibles typically, unless you're getting Medicaid long-term care, will have copays for their prescription drugs. Okay, next slide. So let's just talk about the different delivery systems of Medicaid that dual eligibles are in, because this can be a challenge for people to understand. And I think sometimes people don't necessarily get correct information when they're talking to folks about this. So most dual eligibles in Pennsylvania get their Medicaid through a system that's called Community Health Choices. So this is, you know, there are 3 managed care plans that offer Community Health Choices coverage. There's AmeriHealth, Caritas in most of Pennsylvania. In southeastern Pennsylvania, that plan goes by Keystone First CHC. Then there's Pennsylvania Health and Wellness, and there's UPMC CHC. So the vast majority of dual eligibles get their Medicaid through a CHC plan. But there are some duals that continue to get their Medicaid through the fee-for-service program or the access card. And the dual eligibles that stay in Medicaid fee-for-service, which is what existed before CHC started back in 2018, and then expanded across the state between 2018 and 2020. Prior to 2018, all duals had their Medicaid through the access card. Today, duals that get Medicaid waivers through the Office of Developmental Programs. So these are waivers for adults with autism or intellectual disabilities. There's kind of a separate waiver system for people with those conditions. People in any ODP administered waiver get their Medicaid through the access card. So those waivers are listed on the slide: the adult autism waiver, community living waiver, consolidated waiver, or person family directed supports waiver, or PFDS waiver. Any dual in any of those waiver programs get their Medicaid through the access card. Otherwise, duals who get base services through a county Office of Intellectual Disabilities stay in fee-for-service. And then there's a very small number of people in a program called OBRA, the OBRA waiver, and duals in the OBRA waiver would get their Medicaid through the fee-for-service access card through Medicaid. So I think people forget, especially providers that might be used to seeing duals in CHC, people forget that there are still folks who are dual eligibles who get their Medicaid through access through the fee-for-service system. And then there's a very small number of dual eligibles who are under 21. These are people that are usually, 19 or 20 years old that might get Medicare based on a parent's work history. Those duals under age 21 stay in a different Medicaid managed care system called Health Choices until they turn 21, and then they will move to CHC or to fee for service if they're in an ID or ODP waiver. Behavioral health is carved out. Medicaid's physical health coverage is through community health choices, or fee for service. Then behavioral health is carved out and through a different managed care program. Dual eligibles, regardless of how they get their physical health coverage, are in a different Medicaid behavioral health managed care plan. People don't choose their behavioral health coverage. They get the behavioral health plan that works in the county that they live in. So all of this is confusing, but duals are going to have different coverage based on their situation in terms of whether they get a waiver through the Office of Developmental Programs or not, if they're under 21, and then behavioral health coverage is separate. So for dual eligibles, their Medicare plan choices, they can enroll in any Medicare plan they want to. They can be in a standalone drug plan. Ideally, they would be in one of the zero premium plans, but they don't have to be. They can join a different standalone prescription plan. They'll just have some premium liability if it's not a zero premium plan. They can be in any of the Medicare Advantage plans that are available in their county. They can be in D-SNPs, and if most dual eligibles who are in a Medicare Advantage plan are in a dual special needs plan because there is no premium. But that's not the only choice available to dual eligibles. Okay, I'm not going to cover the billing protections. Just know that certain dual eligibles have billing protections if their coverage is through original Medicare. Medicare providers are not allowed to charge certain dual eligibles for balance billing, the Medicare deductibles and coinsurance. The balance billing protections are broader for dual eligibles who are in Medicare Advantage plans. And then on the Medicaid side of things, Medicaid providers are prohibited from charging anybody on Medicaid any more than the small Medicaid copay that applies to a service. People can refer to that slide and certainly reach out to Katie or I if you have billing questions or have people that are getting billed and you're concerned that those bills are inappropriate. Just some other quick things just to kind of keep in mind. Duals that are in health choices or community health choices, they can pick their Medicaid managed care plan on the physical health side. They can change that plan at any time. They don't have the same enrollment periods that apply on the Medicare side of things. So people who are duals in Medicaid managed care can change their plan throughout the year. Again, Linet is available and is really helpful, especially for new dual eligibles, people that have been on Medicaid and then get Medicare and might find themselves in a gap where they don't have Medicaid drug coverage anymore and they aren't yet enrolled in a Medicare drug plan. There is a best available evidence process for people that are in a Medicare Advantage or Medicare drug plan, but that plan does not have extra help information updated for them. The best available evidence process is a way to provide that plan with proof that somebody has Medicare or has extra help so that the plan can update their systems quicker than they might automatically update. And then another really just important protection to keep in mind, especially as we head into the new year, that Medicare has transition refill requirements, so that if I'm in a plan this year and I switch my plan for next year, and in January, if I go to the pharmacy and find that my new plan doesn't cover my prescription or maybe covers it with prior authorization requirements that my doctor didn't go through yet, that plan has to cover my first refill of a medication that I've been taking within the first 3 months of coverage. So in January, I should be able to get that prescription covered, and then I can either switch plans if I'm able to, or have my doctor request prior authorization or request that formulary exception so I can continue to get my prescriptions after that one-time fill. So, and there's links to the more details about those things on the slide here. Okay, that's a very quick overview of dual eligibility.
All right, and we have a couple of questions.
Yep.
So going back to prescription drug coverage for duals, there was a question about whether Medicare covers Part B meds for duals.
Yes, yep. So thank you, because I skipped over this. So there are some medications that are covered by Part B as in basketball versus Part D as in drug. These would be injections that are administered within a doctor's office. There's some oral anti-cancer medications that are covered by Part B instead of the drug part. So if a medication goes through Part B, Medicaid will pay second. Medicaid pays second to Part B. They just don't pay second to Part D.
Yeah. And then there was a question, I think this was when you were talking about the different delivery systems. If somebody had Keystone First, and I suspect this is somebody under 21, that will go away, and then you must use the access card if you're in one of the ODP waivers.
Yes. Yep. So once somebody turns 21, they would be in fee for service or access only if they're in one of the waivers through the Office of Developmental Programs or if they get base services. Otherwise, so they would stay in access in that situation or the Oprah waiver. Otherwise, duals, when they turn 21, go into community health choices.
Right. Thank you. And I think that's all the questions we have right now.
Okay. All right. Thanks.
All right. So because we are still in this COVID unwinding period, we did want to touch on a few reminders. And, you know, there were certain flexibilities that were in place on both the Medicaid and Medicare side during the COVID unwinding. I'm going to talk about just some reminders on the Medicaid side. So the Medicaid continuous eligibility protections ended in April. Pennsylvania is doing their unwinding for over a 12-month period, April of 2023 through April 1st of 2024. So now that people's Medicaid benefits can be terminated, people who may have become ineligible during the period where they had that continuous coverage still have to be reviewed before they can be terminated. So there are folks who were COVID maintained, they kept their Medicaid eligibility coverage despite being ineligible or maybe despite not returning their annual renewal packets. They get to keep their Medicaid until the next time they're due for a renewal. For folks who aren't COVID maintained, they were continuing to qualify, continuing to send in their renewal packets during the COVID protections. If they report a change to the county assistance office, they can be reviewed at that time and terminated if they're no longer eligible. One thing to remember is that the county assistance office has to review someone before they can terminate them for any other Medicaid category that they might potentially be eligible for. And you can see our Medicaid monthly income and resource limit publication that we included with the materials for the income and resource limits for the various Medicaid programs. So sometimes we'll see someone who is working and they're on Social Security disability, and maybe they no longer qualify for the Medicaid category they were in, but the county assistance office should review them for the MOD program, medical assistance for workers with disabilities, to see if they could qualify for that rather than just terminating them. Anytime the county assistance office is terminating someone's Medicaid benefits or changing or reducing their benefits, they must send a 15-day advance written notice with the right to appeal. And so we have seen some problems with people getting notice that doesn't give them a full 15 days advance notice, just some notice issues generally. People can appeal within 15 days of the date of that notice and keep their Medicaid benefits while their appeal is pending. You have 30 days to file an appeal, so if you miss that 15-day period, you can still appeal. It's just you would not keep your benefits while your appeal is pending. So to make sure people don't miss important information about their benefits, make sure that your address is updated with the county assistance office. You can call the customer service center to update your address. You can do it on the Compass app or on the website. Just make sure that your contact information is up to date and that when you get that renewal packet, you do complete it. So just some reminders for folks who are eligible for Medicare who may lose their Medicaid during the unwinding. We talked earlier about there's the new special enrollment period for people to enroll in Medicare Part B if they didn't enroll in Medicare Part B when they were first eligible because they have Medicaid. They can enroll in Medicare Part B using the special enrollment period, not have any late enrollment penalty, and get that Medicare Part B coverage in place. There's also the guaranteed Medigap guaranteed issue opportunity we talked about. You know, as I mentioned, there's been some challenges using that, but it is an option to try to allow people to enroll in a Medigap without medical underwriting. Just a reminder about extra help, even though people lose their Medicaid, they'll still have their extra help in place at least through the end of 2023. If they're losing their Medicaid after July 1st, they'll still have extra help for all of 2024. And just a reminder that people who are in Medicare or eligible for Medicare, if they're having one of these changes, if they're losing their Medicaid coverage, they likely want to review their Medicare coverage because they're going to have more costs if they no longer have Medicaid as that secondary insurance covering that Medicare cost sharing. So they should get in touch with PA Medi to review their coverage options and make an affordable choice for their Medicare coverage. And I know we're talking about Medicare today, but people who don't yet have Medicare, if they're losing their Medicaid, can contact the Pennsylvania Health Access Network, get online and look at penny plans to find a penny plan that works for you. So just a reminder, so if someone receives a Medicaid termination notice, maybe they received a Medicaid termination notice at the end of you know, sometime in late October, and it says their Medicaid eligibility is ending November 8th. Most duals, as Erin just went over, are in a community health choices plan. Because that plan has already received their payment from the state for the full month of November, effectively, even though they received a notice saying their Medicaid eligibility is ending today, they will have that coverage for the rest of the month. So they've been terminated from the Medicaid program, but because their health plan has already been paid for this month, they have that Medicaid coverage through the end of the month. People who are losing Medicaid can apply for PACE and PACENet if they're over 65. Losing Medicaid gives you a special enrollment period to change your health or drug, your Medicare health or drug coverage. That's a 3-month special enrollment period. So if somebody is, as I mentioned, if you're losing your Medicaid, you'd likely want to review your Medicare coverage, make sure it's still affordable for you even without the Medicaid as supplemental insurance. And so people can take advantage of that special enrollment period to change their health or drug coverage. People who are duals who are enrolled in a dual special needs plan, DSNPs typically offer a 3 to 6 month grace period after someone's Medicaid eligibility ends, because we know we've seen plenty of people who received a Medicaid termination notice when they still were eligible, or, you know, there was something that went wrong. Maybe they got their annual renewal packet, didn't fill it out and send it back in, or maybe they didn't submit all of the resource information they were required to renew their Medicaid eligibility. So their Medicaid was terminated. Their dual special needs plan is going to give them a grace period. They're not going to terminate them right away. They give them a grace period so that if they can get their Medicaid coverage back, they can stay in that plan. But once your Medicaid coverage has ended, you need to check with the dual special needs plan to find out if you are going to be responsible for any cost sharing during that grace period. Generally, I think we hear from people that many people are not charged any cost sharing, but some are. I think it depends on the plan and how they operate. So worth checking about whether you want to just stay in that plan through the grace period, or if you want to just take advantage of the special enrollment period and go ahead and change your Medicare coverage earlier once you lose your Medicaid. We also wanted to highlight, because we are hearing from a lot of people who are being terminated from the Medicaid Community Health Choices waiver program. Now that we are in this unwinding period and people's Medicaid eligibility is being reviewed, people's eligibility for the waiver programs are also being reviewed. In particular, the Community Health Choices program is the folks we're hearing from. So to qualify for the Medicaid waiver program, you have to be both clinically and financially eligible. And you have to have that eligibility reassessed every year. So part of that is a financial reassessment, but there's also a reassessment every year to see if someone remains clinically eligible for the waiver program. We're hearing from a lot of folks who are being reassessed and being found to no longer be eligible. We're seeing a lot of problems with these cases. There are confusing notices. Sometimes people are receiving notices both from the Office of Long-Term Living and from their county assistance office. We wanted to flag this because we are seeing so many cases, and a lot of these cases are people who are dual eligible. They're older adults, they're people with disabilities. If someone receives one of these waiver termination notices, they have a right to appeal and keep their waiver services in place if they appeal within 15 days. And I know we've done a newsletter article about steps that people can take. People should stay tuned with our newsletter. I'm sure we'll be providing updates. But we just want to encourage folks to appeal, because most people who appeal have been found to remain eligible for the program. So definitely want to encourage folks to appeal and fight those terminations. We also wanted to just briefly flag, during the public health emergency, most people could not have their Medicaid coverage terminated. There was a rule issued at one point during COVID that allowed for people who have Medicare to have their Medicaid coverage reduced to just help with their Medicare Part B premium if they qualified for that help. There was a lawsuit filed in 2022 that challenged that rule, allowing reduction of people's Medicaid coverage for people on Medicare. And in January of this year, a federal judge ordered the government to stop enforcing this rule. And also, this is why we're talking about this, to retroactively reinstate anyone who was improperly terminated under that rule. So Pennsylvania is still working to comply with that order. We know some people's Medicaid coverage was reinstated. Some people's Medicaid coverage was retroactively reinstated. But Pennsylvania is still working to reinstate coverage back to when that rule started and when people started losing their Medicaid coverage. Pennsylvania is still working on a system fix to restore that coverage. People who haven't had their Medicaid renewal yet since the COVID protections ended should be getting a notice from the Department of Human Services soon about how to get that coverage going forward, get their Medicaid coverage back. This has been kind of a moving target since this court order was issued. So we wanted to flag it, but again, this is another area where we will be continuing to update folks through our newsletter as things change. But just in case you're working with Medicaid beneficiaries and they get a notice that they're confused by from the Department of Human Services, it could be related to this federal court case, and Pennsylvania continuing to try to comply with that court order. So we will end here with just sources of help. Just as a reminder, folks can call our office if they're having trouble accessing Medicaid coverage or services. People should contact PA Medi for help reviewing their Medicare plan options, applying for the Medicare savings programs, applying for extra help, taking advantage of the special enrollment periods we talked about. People can call 1-800-MEDICARE if they have questions about their Medicare coverage. They can go to medicare.gov, set up an account. And we encourage folks, as I have several times, to sign up for our newsletter. You can follow us on social media, check out our resource library. We have videos on our YouTube and on our website with prior trainings if you want to access those. And you can reach out to me or to Erin if you have follow-up questions.
Great. Thank you, Katie. And thanks to everybody for sticking with us through all that information. We do have a couple quick questions to review. Okay, this question is, my client is over income level due to annuities. What can they do to stay eligible, if anything? And this might be one where we might need some more information, right, to answer.
Yeah, because there's different Medicaid programs with different income levels. So Kim, if you want to reach out about that client, I'm happy to talk about that.
Okay, because there might be ways for that person to still qualify or other categories
Right.
to consider.
Right.
Okay, and then this question is about the car decision. So people who were affected by car and incurred expenses because of their Medicaid being reduced, can they get the money back that they spent on their medical bills?
I mean, I wouldn't hold my breath.
Yeah. I think, yes, I think maybe some information got cut off on that slide. So I'll make sure that it's on there for when I send it back out. But the plan is to systematically retroactively reimburse people for the time frame that their benefits were reduced, and they shouldn't have been now that this court order is in effect. But I think people are going to have to basically contact their providers and tell their provider that their Medicaid got reinstated. The provider can bill Medicaid. They're making some system tweaks so that the regular billing time limits don't apply, to make sure that prior authorization rules don't apply to these retroactive services. But I think we can all appreciate that it's going to be just really challenging for this whole process to play out in a way. There's no automatic refund of people's money that they paid for medical bills when they were impacted by this. So there are steps people can take to try and get refunded for medical bills that they paid. And yeah, I guess I'll leave it at that because we don't know how easily this is going to play out.
But
All
thank
right.
you all for listening today. Please fill out our webinar evaluation that Erin put in the chat, and feel free to reach out if you have more questions.
Yeah, thanks everyone.
Thanks, everyone.
Thanks, Katie.
Yeah.
Okay. All right. Okay. So some problems maybe
Okay.
with the Google form,
Yeah. Thanks
or maybe
for
any.
letting us know. Yeah.
Yeah. All right. Thank you. I don't know.
Do you want to stop the recording?